Okay, this is the second part of musculoskeletal, and we're going to refresh again the most common synovial joints. And remember, they're classified as ball and socket. This is an example of polyaxial joint motion and is possible in many axes. In a ball and socket joint, the articular surface, a reciprocal segment of a sphere. The most common examples of this are hip and shoulder. And remember, they have a wide range of flexion, extension, abduction, adduction, rotation, and circumduction. Basically, you have an extent possible movement. That's the reason why they're called polyaxial. Hinge joint is permits movement in only one axis. For example, they basically only do flexion and extension. The axis is transverse, and the most common example of a hinge joint is the elbow. Condylar type of synovial joint permits movement in two axes. Basically, an example is radio-ulnar joint. The articular surface are oval, so these joints have been described as the egg in a spoon joint. One axis is the long diameter of the oval, and the other axis is the short diameter of the oval. The wrist joint is one example as well, and in addition to that, metacarpophalangeal joint and metatarsophalangeal. So metatarsophalangeal and metacarpophalangeal. Now let's talk about knee conditions. When you're going to examine the knee, the person should remain supine with the leg extended. Although some examiners prefer the knee to be flexed and dangling for inspection. The most common is basically with the leg extended. You have to look at the skin to see if it's color even in color, if there's no lesion, if it looks smooth. Inspect the ligaments, alignments. The lower leg should extend in the same axis as the thigh. Inspect the shape, the contour. Check for signs of fullness and swelling. Also, check for other locations such as the suprapatellar pouch. Check the quadricep muscles for atrophy or hypertrophy, because this is the prime mover of knee extension. This muscle is important for joint stability during weight bearing. So pathophysiological findings of inspection could be, for example, if you have a shiny or atrophic skin, if you're able to notice any signs of swelling or inflammation. We already discussed what henovarum Bolex is, or henovalgum, knock knee. So look for those type of deformities. Look for any type of flexure contraction. Palpation-wise, enhance palpation with the knee in the supine position with complete relaxation of the quadricep muscle. Start high on the anterior thigh at about 10 centimeters above the patella. Palpate with your left thumb and finger in a grasping fashion. Proceed down towards the knee, exploring the region of the suprapatellar pouch. Note the consistencies of the tissue, if it feels soft, if it feels solid. Normally the joint should feel smooth, with no warmth, no tenderness, no nodularity. If you feel any type of fluctuation or if it's boggy, you have to think about possible suprapatellar pouch synovitis. So now let's talk about possible pathological findings when the patients have knee problems. One of those is the bulge sign. And to be able to examine for bulge sign, this is when you're trying to discern if the patient has any type of swelling in the suprapatellar pouch. The bulge sign confirms the presence of small amounts of fluid as you try to move the fluid from one side of the joint to another. So firmly stroke up on the middle aspect of the knee 2 to 3 times to displace any type of fluid if it's present. Tap the lateral aspect. Wash the middle side in the hollow for a distinct bulge from a fluid wave. The bulge sign occurs when there is a very small amount of effusion, for example 4 to 8 millimeters from fluid across the joint. So this is the representation of how you should examine for bulge sign. So again, testing for knee joint effusion is the bulge sign. It's performed by pressing the fluid out of the suprapatellar pouch down behind the patella. So start about 10 to 15 centimeters above the patella and slide your index fingers and thumb firmly downward along the side of the femur, milking the fluid into the space between the patella and the femur. While you're maintaining pressure on the lateral margins of the patella, tap on the patella with the other hand. This is another technique to be able to do the bulge sign. This is the step 2, which is basically tapping. This is the step 3, basically displacing, and see how the fluid waves move. So another cause of knee pain, you could classify them as intra-articular, and they're separated by age population. Between 18 to 30 years old, torn meniscus is the most common. Between 30 to 50 years old, again, meniscus tear, and any type of injury that requires surgery. And in the older adult, osteoarthritis, that will be one of the presentations later on. So let's talk about tears, because we have a comparison table next. Tear may occur in ligaments, and these are called sprains. In muscles, they're called strains. Tears may be graded as minimal, moderate to severe, or complete, which is the 3rd degree. 3rd degree sprains may result in joint instability and are differentiated from the 2nd degree sprain, or moderate to severe, by stress testing. Sprains commonly involve the acromioclavicular joint, but it could also be present in the knee. Tendon tears commonly involving the knee. Most commonly is the extensor muscle or the Achilles tendon, which is involve the ankle. Various muscles are commonly strained. 2nd degree sprains are very painful when stretched, and the 3rd degree sprains often cause joint instability because ligaments that stabilize joints may be disrupted. Diagnosis, basically you do bedside stress testing involving passively opening the joint in a direction other than the normal range of motion. So basically you're stressing the movement to check for joint instability. Treatment is rest, ice, compression, and elevation. So that's the reason why the acronym is called RICE, R-I-C-E. So R for rest, I as an I, compression for C, and elevation E. So basically, mobilization and repair are indicated. Treatment includes, again, the raise, analgesics, and for third degree is surgery. This is the most common ligaments that are damaged or involving any type of knee tear, which is ACL, anterior cruciate ligament, PCL, posterior cruciate ligament, MCL, medial collateral ligament, and LCL, lateral collateral ligament. And we're going to discuss this now in a comparison table. Tear to the ACL may be felt as a pop and is acquired with a non-contact injury. MCL or LCL or meniscus tear or any type of fracture of the knee is most commonly in contact injury sports, such as football, soccer, etc. ACL fracture or neopatellar dislocation, most commonly the patients have an acute swelling, that's the most common sign. MCL tear, patients might feel an intense pain, and the etiology or the causative factor is a lateral blow to the knee. On the contrary, LCL occurs due to a medial blow to the knee. ACL tear or patellar dislocation, the etiology is basically a knee buckle. And the PCL tear is when the patients fall onto flexed knees. Now let's talk about other common signs present in ACL tear. So to be able to palpate collateral ligaments, the patient's foot should be resting on the bed with the knee flexed at 90 degrees. So grasp the patient's leg and using your thumb, try to elicit tenderness over the patellar tendon beneath the femoral epicondyle. Another test for collateral ligaments rupture is performed by placing the examiner left hand on the lateral aspect of the patient's knee at the level of the joint. The knee is flexed about 25 degrees and the lower leg is pushed outwards by the examiner's right hand, with the left hand acting as the fulcrum. This maneuver is an attempt to open up the medial side of the knee joint. The results should be compared with that on the other side, and any abnormal lateral motion is seen in rupture of the medial collateral ligament. Now let's talk about the ACL or the cruciate ligaments, and this is the most important to remember, is called the drawer test. And the drawer test is used to test for rupture of the cruciate ligaments and anterior cruciate. The patient is instructed to lay flat in bed, flex the knees at 90 degrees. The examiner should sit close to the foot to steady it. The examiner then grabs the leg just below the knee with both hands and jerk the tibia forwards, as illustrated in the figure. Any abnormal forward mobility of 2 centimeters or more is subjective of rupture of the anterior cruciate ligament. This maneuver can be used to test the posterior cruciate ligament as well by flexing the knee 90 degrees, steadying the foot, and attempting to jerk the leg backwards. Any abnormal backward motion of 2 centimeters or more indicate rupture of the posterior cruciate ligament. So these two you need to remember for the exam. McMurray test is another test to be able to test meniscal tear. And basically, what you do is hold the heel. So basically, position the person supine as you stand on the affected side. Then hold the heel and flex the knee and hip. Place your other hand on the knee with fingers on the medial side. Rotate the leg inward and out as well to loosen the joint. Externally rotate the leg and push inward to stress on the knee. Then slowly extend the knee, and normally the leg extend should feel smoothly with no pain. If you hear any type of click, McMurray test will be positive, and this is a sign of meniscal tear or torn meniscus. Now let's talk about flat feet. Flat feet, or the same as pes planus in Latin, is a postural deformity in which the arch of the foot collapses, with the entire sole of the foot coming into a complete near complete contact to the ground. Causes for flat feet is very common in infants. It's actually called baby fat, which makes the developing arch, and partly because the arch has not yet fully developed. So this is very common in infants. The human arch develops in infancy and early childhood as part of the normal muscle, tendon, ligament, and bone growth. Training on the feet, especially for gymnastic and walking barefoot, can facilitate the formation of the arch. Treatment, basically, again, going barefoot. So tell the patient to walk without shoes, particularly over terrains such as the beach, when you're doing any type of workout. You could also do ligament laxity, and this is done by surgery. You could also tell the patients to wear closed-toe shoes, sleepers, sandals. Now let's talk about the ankle and the foot joint. What should you inspect while the person is in sitting position, bearing any weight? Compare both feet. Note the position, the toes, the contour, the skin characteristics. Look for alignment. The toes normally should point straight forward and lay flat. The ankles or the malleolus should look smooth. Note the skin. The skin should be also smooth, even color, with no lesions. Try to look for the presence of calluses or any type of bursal reaction. Try to look for any type of pathology such as hallux valgus. which is the distal part of the great toe, is directed away from the body midline. Look for hammer toes. We're going to discuss this in a second. Any type of swelling, inflammation. Again, hallux valgus or bunion. And we're going to discuss the meaning for that. This is basically the anatomy of the foot. Just to remember all the type of ossifications that we have. Again, assess for any type of swelling, deformity, any type of flat foot or an excessive arch. When the patient is walking, look for the gait, any type of pathology, range of motion. Check for hallux abductovalgus, which is the same as bunion. And what is bunion? Bunion is no more than a prominence of the medial portion of the head of the first metatarsal bone. The cause is various, but most of the time occurs in the great toe, secondarily to osteoarthritis or any type of spur formation. Symptoms is pain and redness. Contributing factor, excessive foot pronation, wearing tight and pointed toe shoes like women. We use this a lot. Any type of trauma, any joint misalignment such as osteoarthritis, synovitis could occur as consequence of bunions, joint swelling as well. Symptoms, again, pain and swelling. When you look at the joint, you see a swollen bursa, warm, red. You see a fluctuation of the swelling because this is a synovial fluid that could be displaced. Diagnosis for bunions is clinically, but you could do an x-ray as well. Treatment for that, most of the time cause a mild discomfort that may lessen by wearing a shoe with a wide toe box. So instead of buying regular shoes, you should buy wide. If not, you could use pads that are purchased in many pharmacies over the counter. You could use any orthotics devices to prevent friction, and the ultimate goal is surgery. Hammer toe, this is another condition of the foot, and hammer toe deformity is a Z-shaped deformity caused by a dorsal subluxation at the metatarsal phalangeal joint. The cause, again, is a misalignment of the joint surface due to genetic predisposition. Rheumatoid arthritis and neurological disorders are associated with this disease. The most common joint is the second toe. Treatment, again, shoes should have a wide toe box, so never buy regular. You could use toe pads that are sold in the pharmacy, and again, the ultimate goal is surgery. This is the bunion or hallux valgus right here, and this is the hammer toe. You have the hyperextension of the proximal and flexion of the distal metatarsophalangeal. Now let's talk about osteoporosis. Osteoporosis, remember, is a progressive metabolic bone disease that decreases bone density or bone mass. Skeletal weakness leads to fracture with minor or inapparent trauma. Most common in the thoracic and lumbar spine, wrist and hip, but it could occur anywhere. Diagnosis, remember, is by bone densitometry or DEXA scan. And if you remember, the pathophysiology of the disease is no more than osteoblast versus osteoclast. The arrangement is one of the most common metabolic bone disease in North America. It could be genetic, it could be diet or hormones. Remember, this is no more than an imbalance between osteoblast and osteoclast that leads to bone tissue demineralization. Risk factors for this: there's family history, white race, increased age, female sex, small stature, fair or pale skin, thin, body build, early menopause, and late menarche. Other risk factors: nulliparity, so the less amount of estrogen containing hormones is a high risk for osteoporosis. Weight below the average, metabolic acidosis, any type of low calcium or vitamin D. So parathyroid disorders is also associated with it. High caffeine intake, sedentary lifestyles, smoker, excessive alcohol consumption, and any type of autoimmune disease or liver or kidney disorders that impede the excretion of phosphate and impairs the metabolism of calcium. Clinical manifestations, most likely none, but it could be associated with pain and bone deformity. It could produce spontaneous fractures, kyphosis, and also remember, anytime a long bone is fractured or demineralized, could trigger the formation of pulmonary fat emboli, pneumonias, hemorrhages, and shock. Classification for osteoporosis, if you recall, is primary osteoporosis and secondary osteoporosis. Primary is the most common. It's more than 95% present in women and 80% in men. Most commonly occur postmenopausal due to gonadal insufficiency. Other contributing factor, we already discussed it, and secondary osteoporosis is less than 5%. And the most common causes are cancer, chronic kidney disease, any type of chemotherapy, hypophosphatemia, liver disease, prolonged immobilization. Diagnosis again is by bone densitometry, and if you remember the values, you have to look for the T-score and the C-score. The T-score, remember, that corresponds to the number of standard deviations that the patient's bone density differ from the peak bone mass of a healthy young person at the same age, sex, and ethnicity. If you remember the cutoff value that the World Health Organization approved, the T-scores for osteopenia less than minus 1.0. What defines osteopenia? Again, I'm sorry. T-score less than minus 1.0 and more than 2.5 minus defines osteopenia, and a T-score less than minus 2.5 suggests osteoporosis. If we're going to discuss the Z-score, remember that this corresponds to the number of standard deviations that the patient's bone mineral density differs from that of a person of the same age, sex, and should be used for children, premenopausal women, or men less than 50 years old. If the Z-score is less than minus 2.0, bone densitometry is low. For the patient's age and secondary causes of bone loss should be considered. Again, the T-score, which is very important. T-score less than minus 1.0 and more than minus 2.5 is osteopenia, and less than minus 2.5 is osteoporosis. And this is what this table is trying to represent. Treatment, remember that risk factor modification is the most important. You should add calcium and vitamin D supplements. Remember the anti-resorptive drugs, which is the biphosphonate, hormone replacement therapy, selective estrogen receptor modulators, and receptor activators of RANK inhibitors. You could also use analog drugs. There's no cure. What we're trying to do is to slow osteoclast formation and bone loss and promote osteoblast or bone deposition and formation. And this is basically the treatment that we just discussed. Prevention is the key. How do you prevent? By giving calcium, vitamin D, magnesium, regular and weight-bearing exercises, avoid tobacco abuse and glucocorticoids, no alcoholism, hormone replacement therapy, parathyroid hormone, testosterone for men, and also possibly for women. So basically target the risk factors. Now let's talk about the last two topics, which is no more than a comparison of osteoarthritis versus rheumatoid arthritis. Now let's talk about osteoarthritis. Remember that osteoarthritis affects one or more weight-bearing joints. The most common are the proximal interphalangeal joint, and these are hand, wrist, cervical spine, lumbar spine. Symptoms increase with activity and diminish by rest. Usually there's no swelling or redness. Sometimes there's nocturnal pain. And again, the symptoms are pain, stiffness, swelling, tenderness. Remember that osteoarthritis is chronic arthropathy. It's a disruption and potential loss of joint cartilage. Includes the presence of bone hypertrophy or osteophyte formation, and the symptoms are gradual, developing pain aggravated or triggered by activity. The stiffness in this case lasts less than 30 minutes and is upon awakening and after prolonged inactivity. Remember, the pathophysiology of osteoarthritis is basically the diminished amount of proteoglycan. Normal joints have little friction with movement due to proteoglycan. Hyaline cartilage is avascular, aneural, and alymphatic. 90% is composed of water, and a matrix, which is full of chondrocytes, and proteoglycan, which provides support, health, and avoids compression. Symptoms, again, remember, the onset is gradual. begins with one joint. This is one of the examples of monoarticulars that we discussed in the first PowerPoint presentation. Then could become bilateral. Pain is one of the earliest symptoms. Pain, again, is usually worsened by weight-bearing exercises and relieved by rest. Stiffness is less than 30 minutes and lessens with movement. As osteoarthritis progresses, joint motion becomes restricted and tenderness. Patients complain of crepitus and like a gritting or grating sensation. Proliferation of the cartilage, bone, ligaments, and tendons could produce osteophytes. In addition, patients could have acute severe sinusitis. The most common joints are the carpal metatarsal joint, carpal metacarpal joints, the intervertebral disc, hip, knee, the PIPs, which is the proximal interphalangeals, and the DIP, which are the distal interphalangeal, less common. And remember that patients could have also the presence, which is pathognomonic, Hebenden nodes and Bouchard. So HBERDEN, and the second node deformity is called Bouchard, which is BOUCHARD. This is basically statistics. The incidence is the same in women as male. Exceptional stress for joints, for example, gymnastics, or if you're constantly kneeling down, obesity would increase the presence, and patients could have more associations of meniscal tears. It could be secondary when it's associated with no known risk factors, or it could be idiopathic. And again, the pathophysiological characteristics are erosion of the articular cartilage because of decreased fluid and proteoglycan, sclerosis of the subchondral bone, and formation of bone spurs or osteophytes. Evaluation is basically due by clinical assessment and radiological studies. You could do x-rays of the hip, the knee, etc. And the x-ray most likely will reveal the presence of osteophytes, also narrowing of the joint space, increased density of the subchondral bone. Sometimes you could see some chondral cyst formation, bone remodeling, or effusion. Laboratory studies that may be required to rule out other causes of monoarticular disorders, such as infection or inflammation process. And if you remember the drug therapy in pharmacology is your Tylenol for pain, or NSAID, because this is classified as mild joint pain. Physical measures, moderate weight loss in overweight patients, reduce progression by rehabilitation. Try to do range of motion exercises. Isometric is more important than isotonic, but you should do both. You should modify activities of daily living. For example, a patient with lumbar spine, hip, or knee osteoarthritis should avoid soft chairs and recliners in which posture is poor and from which rising is difficult. Other drugs that could be used tramadol. You could use any type of hyaluronic acid that is sold over the counter and in many natural medicine drugstores. Glucosamine with chondroitin. In research, it's been proven that it works. But it has a questionable absorption. These are the Haberden's notes in the distal phalangeal and the Bouchard in the proximal phalangeal. Now let's talk about polyarticular or systemic systemic joint disease, which is rheumatoid arthritis. Remember, this is an autoimmune disorder. It's chronic, systemic, involves many joints. And remember, the main pathophysiology is that the damage is mediated by cytokines, chemokines, and metalloprotease. The most common joints are the wrist, the metacarpophalangeal, and this is a symmetric inflammation leading to progressive destruction of articular structures, usually accompanied by systemic manifestations. Again, it's an autoimmune disorder. It's mediated by IgM and IgG, targeting the synovial membranes, forming antigen-antibody complexes. There's a questionable bacterial or viral infection, such as mononucleosis. Remember that initially affects synovial membrane, later cartilage, joint capsules, ligaments, and tendons. We discussed already the most common joints that are affected, such as the wrist, proximal interphalangeal, metatarsophalangeal, shoulder, elbows, hips, knees, ankles, and is symmetric bilateral, and is associated by systemic manifestations. Never forget the serositis. It's basically an inflammation of the serosa, which is the pleura, the pericardium, the peritoneum. So patients would have pericarditis with effusion, pleuritis with effusion as well, and they could have peritonitis. Very common to have nephritis and renal insufficiency, and also it's associated with subcutaneous nodules. Is very common, associated as well with other autoimmune diseases, such as Sjögren, such as lupus. There's actually a clinical criteria for rheumatoid arthritis. Is symmetric, is inflammatory, is associated with systemic manifestations such as fever, leukocytosis, anorexia, that is not present in osteoarthritis. You would study in details the criteria for diagnosing rheumatoid arthritis in your clinical specialty areas, but briefly, the main criteria is that you should have at least one joint with synovitis, and this joint is classified by points. Okay, actually will give you a 0 point if it's a large joint, 1 point if it's 2 to 10 large joints, etc. If you have rheumatoid arthritis factor positive and the antibodies would give you 3 points. And if you have negative, is less points. If you have associated with the symptoms, you have an increased SED rate or any type of inflammatory mediator factor, will give you more points. And depending on the duration of the symptoms, if the symptoms last more than 6 weeks, it will give you points as well. Remember, this disease process, it could range from mild to severe. It destroys and distorts the joints, reduces the life expectancy of the patient. Patients complain of remission and exacerbation. This one has a big difference in women with male, with a ratio of 3:1. The onset could be between 20 to 30 years old, and this is the juvenile rheumatoid arthritis. The symptoms lessen with pregnancy, and it has a seasonal variation. Again, how can you note different findings in the hands? Swelling in the proximal interphalangeal or metacarpophalangeal. You could see the swan neck deformity or the boutonniere deformity. Patients have associated systemic manifestations such as fever, weakness, malaise. Evaluation, again, although clinical evaluation is relevant. X-rays, you could see all the deformities. Serological test, you would do an ANA, rheumatoid factor, and also circulating antigen antibody complexes, such as the most specific for rheumatoid arthritis is antibody against cyclic citrullinated peptide. And there's no cure. But if you remember the treatment for this disease is supportive measure with nutrition, rest, analgesics, drug modifying rheumatoid arthritis, NSAIDs, and it could include opioids. You could give prednisone, methotrexate, you could also give any DMARD, which is the traditional disease-modifying anti-rheumatic drug. And these are your hydrochloroquine, your methotrexate, if you recall from pharmacology, sulfasalazine. You could also provide intra-articular injections of prednisone or triamcinolone, or provide systemic oral prednisone as well. You can use immunomodulators such as cyclosporin or azathioprine. You could use rituximab, etc. In addition to that, you could use anti-malarial drugs and surgical procedures or cytovectomy to be able to correct the deformities and improve function, joint replacement, and joint fusion. This is no more for improving lifestyle. These are the boutonniere deformity, and this is the swan neck deformity, pathognomonic for rheumatoid arthritis. Thank you for your attendance, and this is the end of the second part of musculoskeletal.